Dr. Ajay Arora, and after that we'll discuss. Yeah.
So at the outset, I must thank Malay for this, innovative and thoughtful IC he has put together. I wish it was held during the daytime, not at 8 o'clock in the morning for more audience participation. Can I have my slides, please, sir? वहाँ पर
I think one point I'd also like to add in both EELS disease and PDR would be the undoubted role of vitreous itself as a scaffold. So like these cases with the recurrent hemorrhages, I think in early vitrectomy, when you have these cases as per your experience in EELS disease, when he's developing proliferation with flat membranes and has a first episode of vitreous hemorrhage, maybe just before, prior to that, would that be a good time to, because that will improve the oxygenation as well as the VEGF load could come down?
My concept until now has been that if the hemorrhage is not resolving on the first go, in a meaningful manner, I think we should go for a vitrectomy. But that chronic kind of hemorrhaging is perhaps due to
Inflammation.
ongoing inflammation.
That would also require a vitrectomy. You think so that would also, that would not be an indication of vitrectomy.
So my talk is on DME therapy current status, and we will overlook these basic definitions because this slide was made based upon various definitions, and all of us must understand the differentiation between CSME versus the classification which is put together of a center involving diabetic macular edema and a non-center involving diabetic macular edema. And it is extremely important to understand that it is the central 1 millimeter area which is the center involving diabetic macular edema. It is not the entire macula which sometimes people consider, though we tend to give intravitreal injections to patients even beyond the central involving diabetic macular edema and not do lasers. The cascades I will not go through, but it is also important that patients who need a good metabolic control, like for this patient, this was many years back. He was one of those people who was very much into yoga and self-healing. He refused any treatment, and you see how the response was after 6 months. Dramatic reduction of the heart X-rays, dramatic reduction of macular edema with no anti-VEGF injections. So it's very important that all diabetics at all stages must be treated with a good metabolic control. This patient came to me in a multi-speciality hospital, first time. Patient, this is the sort of edema the patient had. We did not give any anti-VEGF injections. Patient was put on dialysis, and see 8 months later how beautifully the macular edema is dissolved. So what I'm saying is it's important to take care of the metabolic status, take care of the kidneys, because that's how it works well. This is a patient who had thalassemia major, and her macular edema was not reducing. This is again 2008. It just happened to be mother of a very important lawyer in Delhi, and later on he's become a good friend. So when he came to me, we were injecting Avastins, and then I said, okay, let me inject Lucentis because I wanted to top it up over what others had done. But it did not improve his hemoglobin. Her hemoglobin did not go beyond 9. And that stage, vitrectomy was not done for non-tractional diabetic macular edema. I went ahead and vitrectomized both the eyes when there was no definitive proof available for doing a non-tractional edema diabetic vitrectomy, and it has worked. She was happy for a long time. This is again just to show you what an laser means for an extra foveal laser and how beautifully these patients respond. I will not go through these anti-VEGFs. This is just to show you some of the slides that whenever the patient comes to you, the OCT may not be very clearly representative. Just go ahead and treat them, and how patients respond well after multiple injections. Initially, the anatomy also will be very difficult to understand, but it's very important to go ahead and treat them and manage them. then all cases of tractional diabetic macular edema must undergo a surgical intervention. Don't keep on injecting these patients because it doesn't really work. So this is just some examples of this thing. This is to show you that there are factors other than VEGF like the ICAM, IL-6, MCP1, pigment epithelial derived factor which have a role, and there was a meta-analysis which showed the relevance of these factors. It's important to recognize the biomarkers of inflammation and diabetic macular edema, and these are some of the biomarkers like the hyperreflective dots, the hyperfluorescent diffuse DME, foveal hyperautofluorescence, and neurosensory detachment and cystic spaces. So whenever I find patients who have cystic spaces or hyperfluorescent dots, my treatment in these cases is more towards giving steroid. And this is an important table. I wish you could just remember this, that what are the biomarkers which correlate well with anti-VEGF, what are the biomarkers which correlate well with steroids. So whenever we give corticosteroids, the corticosteroids have both effect, an anti-inflammatory effect and also an anti-VEGF effect. And this has been shown in many of our cases whom we have treated with steroids, and they have responded extremely well. I'll now come to, can I run this video? I hope it runs on this. Okay, let me see. So this is just to show you how we inject suprachoroidal injections. This is a very simple device. It has now it has got almost patented. I've received the initial communication, and this will then soon be able to send it for somebody to manufacture it. And this, I have a very large series in these cases, and it has done well. So this was an example. Suddenly in India, in about 2-3 years back, we had a short supply of Ozurdex, and the patients with persistent diabetic macular edema, you can see how bad the macular edema looks. This is a patient who had a cup disc ratio of 0.7, was an anti-glaucoma treatment, and this was one of the initial cases of diabetic macular edema whom I had injected suprachoroidal injection, and you see this beautiful response after SKITA in these cases. There are multiple cases like this. There are defined URETNA guidelines of using corticosteroids in these cases, but basically if you have a patient who has got a cardiac event in the past, corticosteroid should be used. If you have inflammatory biomarkers positive in a diabetic macular edema, you have to try to use corticosteroids, and it works pretty well. So there's now, as Ajay Dudani mentioned about the use of micropulse laser, I will not go into the physics behind it, but it's been shown that micropulse laser works well in diabetic macular edema by multiple studies. This was one of the initial studies of Vojovisk, which had shown that even the microperimetry was maintained in these cases which were treated with micropulse laser. This is an example of a patient who had an extrafoveal edema. We treated with micropulse laser, and the patient responded well. I have been doing now treating patients with proliferative diabetic retinopathy with DME, and I have more than 10 years follow-up in about 3 patients who are willing for undergoing micropulse laser. We had taken a special consent because these patients, I am doing a treatment other than PRP. So this is follow-up of one of those patients whom he comes to me once a year. So you can see the octa images over last 5 years, how the superficial capillary plexus, the deep capillary plexus has changed in these cases, and and these patients I have not given, we have not done a PRP for him. So this is his pattern of after a wide field angiography. You can see the areas of capillary non-perfusion. So these are the areas which I have done only micropulse laser. Whenever we detect an NV that is treated in a localized manner, rest of the areas is maintained. What is the advantage of all this? We have been able to maintain the fields. So I've monitored the fields since last 4 years. The field has not deteriorated. The patient comes to me once a year. Once a year I give a micropulse laser in these cases. I don't have to inject into them anymore. So micropulse laser with a combination of continuous wave laser is doing well. Like persistent DME patients sometimes can have, you should do a wide field angiogram. Like in this particular patient, you will have large area of capillary non-perfusion. You can see those leakages. You laser those areas, and once you laser those areas, gradually the edema comes down. You again do not have to keep injecting them. Try to find out the offending cause, and it really works very well. So these are the various biomarkers which correlate with visual acuity. I will. There is. I think paucity of time and not talk too much about drill, but it is extremely important. And it's extremely important for all the cataracts, all those who are doing cataract surgery, that you must treat diabetic macular edema before you take up the patient for cataract surgery. This is what happened to a patient who was not treated well. 2 weeks post cataract surgery, this is the situation they landed up into, and this can become medico-legally important. This is an algorithm which we made, which was published, and this is how a DME is to be treated. And the key takeaways from this talk is good metabolic control. Anti-VEGFs are the first line of therapy. Steroids have a significant role. Intravitreal corticosteroids act by the anti-VEGF property and block inflammatory mediators. Suprachoroidal steroid injections are showing very good results and can be made to work for a longer duration of time. Now what we are doing is we are centrifuging our triamcinolone, and our centrifuge triamcinolone, what I'm using, works for 7 months. There is not one product in the market that works for 7 months. That means I give 2 injections a year and it's working extremely well. Thank you very much.
Yeah, fantastic. And his suprachoroidal thing has really revolutionized. And there was a question from this lady sitting next to Partha Vishwas. Yeah, you please come.
Oh, we are so glad that Dr. Partha is here. Maybe it's the next welcome, President, sir.
And till she is asking question, Dr. Partha, we had a very good session. This is discussing a new thing, inflammation and neovascularization in retinal diseases. And it was a very interactive session, like Professor Ajay Dudani was there, Sandeep Saxena told about EASE disease, and we had a very nice presentation. The only thing people are saying that a better slot would be useful in the times to come.
Maybe now Partha is here, we'll get a
Yeah, that's what I took the opportunity, because a very yeah, a quick comment and then we will wind up.
Sure. Hi, this is Dr. Kiran Turaka. I'm from UPMC Harrisburg. Congratulations, Dr. Ajay. Great talk. Great talk. So you know that when we are doing, you're talking about controlling the systemic disease is important before even we kind of shoot an injection or shoot a laser or do the things. So same, I'll ask you, like for your patients, when you said that you kind of have to give these injections repeatedly, but still like there is a kind of subclinical kind of vasculitis there. So my question to you is, how about treating the systemic thing? Is the patient having any kind of active tuberculosis or a secondary tuberculosis? Has it been addressed in the past in those patients who are getting like kind of recurrent vasculitis? Were they treated in the past, or do they have anything kind of active infection now?
So my patient was treated for tuberculosis about 10 years back. When he was a child, he had received a full treatment with AKT.
Sure.
So I, repeated his Mantux. He was about 10 millimeters. So I told him, let's do a repeat course of, AKT based on that, because you're getting recurrent. But he was very, refusing to take a repeat course of treatment. So he took a chest physician's opinion, and he also was saying that there's no need for AKT. And he was refusing. So most patients don't want to go again for that 9-month-long therapy, these
Right.
EELS patients. So.
Yeah.
So I was stuck up in this patient.
Right. Yeah, but you don't have to give every time 9 months treatment, and Mantu is not going to help much because being
True.
Indians, we all have
Yeah.
we get BCG vaccine, so we already will have
True,
a positive
true.
Mantu. Like getting a quantiferon gold.
Yeah, that
or-
was negative.
That was also negative.
HRCT
Okay.
chest was negative. So
Right,
then
right.
the chest physician was very reluctant. So I think what Sir said, maybe I could, give him, I'm giving him steroids, but I think switching him to Azoran with steroids might help, is what I was thinking.
Right. But whenever we are kind of giving the steroids, there is kind of a flare-up
Reactivation.
of the infection.
True,
so
true. Yeah,
then
it's
you
a-
got to be kind of extra
Very true.
cautious while giving the steroids
I
for
agree.
any patient with the past history of tuberculosis. Even if they were treated like 20 years ago,
Right.
they kind of get the flare-ups.
Very true. I agree with you on that.
All right.